Yeah, so let's move ahead with this. And so we all know that a lot of drugs have come up which do say that they're going to reverse aging, and I'm not sure if that is actually very possible. But yes, there are some things which can help us and which might improve our outcome, especially in ART practice. And it is now the time when we're talking about when elder age group female are coming to us and they want to conceive with their own eggs, and that's when these adjuvants come into play. We know, what do you understand by adjuvants? Adjuvant is a very simple word, and in dictionary it does say that serving to aid or contribute. So it's going to contribute to the conventional protocols which you will be using for such cases. So any pregnancy above the age of 30, we know that there is a higher incidence of aneuploidies and chromosomal abnormalities. The oocyte and the embryo quality will fall down. There is some problems with the sperm dynamism during if the age group is higher. And for this, we have to improve our IVF and ICSI implantation rates. And how do we actually do that? So sometimes when we know that there is age-related fatigue or there is menopausal fatigue, we would like to add adjuvants, and these adjuvants help to improve the follicular microenvironment. So in the last slides, we saw that we did discuss ovarian response, and there are three kinds of ovarian response which we discussed. There was normal responders, there was poor responders, and there was excessive responders. And then came, before starting any ovarian stimulation protocol, when a patient comes to you and wants to start an ART cycle, there's some things which you have to keep in mind. The first important thing which we keep in mind is the analysis of the ovarian reserve. Once you understand the ovarian reserve, the second important thing is to define the goal of ovarian stimulation. How many oocytes are you predicting, and what is your main goal for this stimulation? Whether you want to freeze all, whether you want to transfer day 2 or day 3, or whether you are planning to transfer a blastocyst. Then the third important thing which we keep in mind is to select the correct stimulation protocol. So when we talk about conventional markers, which we were talking about, everything comes into mind is it actually very possible to select the correct stimulation protocol? And I would say yes, a few things would give you hints on what important things which you should understand, which will help you in choosing the protocol. The first important thing when you talk about prediction of poor ovarian response, and which I'll be stressing more upon, is the age. Anything above the age of 36 years is going to be an important marker in predicting your response. We actually do not do day 2, day 3 FSH levels now. The second important thing which we focus on is your AMH values. And the third important marker is transvaginal ultrasound done on day 2, day 3 for antral follicle count. So these three parameters are going to help you in predicting your ovarian response. Now, when we talk about adjuvants, the role of adjuvants actually come into play when we know that the age group is high, and we know that this patient wants to conceive from her own eggs, and that's where we would like to offer her some adjuvants, because even one single extra egg or one single extra M2 oocyte will definitely help her in her cycles. My whole talk will be based on evidences and the Cochrane reviews, and what do the studies tell us whether we should use this adjuvant, on where we should use this adjuvant. And my first adjuvant today is human growth hormone. It was very popular a few years back, and for till last year we also have been using human growth hormone and then a lot of studies started coming up. So how does this human growth hormone actually help us? We know that growth hormone enhances the response of granulosa cells to the gonadotropins, and so it actually acts by increasing the local production of insulin like growth factor 1. And this insulin like growth factor 1 plays a very important role in ovarian steroidogenesis. So most of these adjuvants which we talk about actually affect the ovarian steroidogenesis. And then came a lot of studies and a lot of confusion suddenly in 2018 and 19 on why and whether we should use growth hormone or not. Because of confusion, various studies were usually inconsistent, and some studies would give you definite conclusive that yes, it is important, and some studies will give you exactly opposite findings, and that is why these studies kept creating a confusion. Also, because we could not do a complete strict double-blind study in such cases, therefore that is why was another reason for confusion in using growth hormone. So I have compiled a few important studies which have been done from 2012 to 2019, and this was a very important article which told us that the benefit of growth hormone expressed in frozen embryo transfers did imply on improved qualitative aspect of the oocyte. So one thing which we know is that growth hormone will improve the quality of the oocyte, especially in elder age group. Then also showed another study came in 2017, which was important, was that in recurrent implantation failure patients receiving growth hormones, they had also shown improved endometrial receptivity, so that they had thicker endometrium and therefore a higher pregnancy and live birth rate. So maybe recurrent implantation failure patients might benefit with a little bit amount of growth hormone because it does show to improve the uterine receptivity. Then another study came in 2018. So this study did only included women who were above the age of 40, and they did say that a little bit addition of growth hormone to the treatment will increase your live birth rate. The second important adjuvant which we will talk about is DHEA, and it has been used a lot by most of us, not even from the non-ART practicing gynecologists. And we have to understand that DHEA also has limited role, and DHEA can also benefit only if given for a proper time interval. So where will this DHEA help us? It of course helps us in poor responders, and we know that our body produces DHEAS and these levels decline with increasing age. And once if you provide DHEA from the external environment, it actually works in improving steroidogenesis, and it might decrease your miscarriage rate, and that's where DHEA will help. So we know that DHEA is an endogenous steroid hormone, and we understand that it is produced from cholesterol through to cytochrome P450 enzyme. The second mechanism where DHEA acts as like growth hormone, DHEA also increases insulin-like growth factor 1. Effect of DHEA is actually seen as cumulative effect. So that also we have to keep in mind. So once DHEA came into being, we also did a study in our center at Rainbow IVF, and we studied almost 100 women who were given DHEA and 100 who were not given DHEA, seeking infertility with poor ovarian reserve, or they had an AMH of less than 1 and an antral follicle count of less than 5. And our primary outcome for this study was an improvement in serum AMH levels, improvement in antral follicle count, and the secondary outcome was to see whether the difference in the effect of DHEA supplement between younger and older patients. So we did observe that women less than in the age group of 35 years old, so women who are less than 35 years old will show a better improvement in antral follicle count in AMH than women who were more than 35-year-old. And yes, we did have a comparison. We gave DHA for a maximum of 3 months, and we did not, then we repeated the AMH levels, and we did see a slight improvement in the baseline AMH levels after 3 months of cycle of DHA. And how is DHEA given? That is a 75 milligram sustained release tablet which has to be given once daily for 3 months. We also saw a little bit improvement in the antral follicle count. So we know that infertility population in our world is increasing, and most of it is because of diminished ovarian response, and maybe drugs like adjuvants like these might give us, if proof possibility of improvement in ovarian response might help us. So in our small study, which was for 100 cases, we did see an improvement in AMH and antral follicle count, but this improvement was better in younger age group. So then I went to Cochrane, and we did see a lot of studies Cochrane also came up with, and they also were confused between the studies which were done in 2013, 16 and 15. Some studies did tell us it was beneficial, and some studies did that it did not improve the live birth rate outcome. The third adjuvant which we talked about was androgel, and androgel is something which we are using in our center, and we have also done a study on this. And how does this androgel work? So ovarian testosterone increases the response of antral follicles to stimulation, which declines with age, and it also improves the insulin-like growth factor. So, increased circulating insulin, IGF-1, and exogenous testosterone, and increased local ovarian testosterone concentrations due to the aromatase inhibition